Hi, everyone, and welcome to episode 13 of the Economic Forces Podcast. I'm Brian Albrecht of the International Center for Law and Economics, and I'm joined by Josh Hendrickson, who's at Ole Miss. This podcast is meant to supplement our weekly newsletter, which you can find at pricetheory.substack.com. Who are we chatting with today, Josh?
So our guest today is Chris Brunt. He's the Shirley and Philip Solomon's Endowed Chair and Professor of Economics at Georgia Southern, and he specializes in health economics. And Chris and I have known each other for a long time. We went to grad school together, so I probably know the answer to this question. But we usually start off people with like an intro kind of thing about like how did you get into economics?
So I actually got into economics by accident. I started out actually in pre-optometry, which is basically the pre-med curriculum. And what I noticed was that I hated being in labs because you were just sort of rushed through with no real explanation. And then I switched to straight math. And in terms of the core curriculum, I had to select a two-course sequence, and economics happened to pop up. And I wound up taking economics by accident and kind of fell in love with it in terms of optimization.
A little bit of that math background. I was a physics undergrad, and one of the things that frustrated me was being in the lab staring at lasers forever. I couldn't do that, but staring at a whiteboard for some reason that was okay once I got the math from that.
All right, so you specialize in health economics, and I see health economics as a place where price theory is particularly important because we have government programs like Medicare that set reimbursement rates for doctors, and so that means physicians are going to optimize on margins other than price. Right? We have programs and regulations that try to regulate price and quality. We have doctors that are not only telling you what care you need, but they're providing you with the care. They, like if you think about health insurance seems much more generous than other forms of insurance, like car insurance, and so that should affect people's incentives. And but when I look at health economics as a field, I don't see a lot of price theory. Okay, but when I look at your work, I do see a lot of price theory. I see you doing effectively applied price theory. So do you agree with that? And how would you kind of characterize your work?
So I hate to start out with a criticism of the subdiscipline in economics, but when I
That's one of
look
the
at
things
all,
that's what we always do. We just complain
yeah,
about everyone. That's what this podcast
yes.
is.
So when I look at a lot of work, I'll even see people claiming that they're estimating demand for something. And when I look at the actual underlying models that they're running, there's no price involved. And I find that really problematic. As I've kind of progressed in terms of research topics, I've kind of tried to stay true to focusing on the impact of regulatory incentives and pricing. And I would say that I don't see a ton of that throughout the literature. There are some people who are still focusing on that, but there's a lot of health economics that seems to have deviated into something else. I
There's
think that's
I think
probably
that
where I
that's
would go with that.
there's fair for a lot of different fields and we go different areas, and that's fine. So let's talk a little bit about Josh mentioned a few in terms of regulation and prices. There's lots of distortions or complications, let's say distortions too low, complications with insurance and whatnot. But your work is a lot of it is focused on Medicare, Medicaid type of program. Could you tell me a little bit at a 10,000-foot level, how does pricing, how do they come up with prices? How do they try to set prices from the regulator's point of view? Where do these prices come from? What do they do?
So let me give you a little bit of history, at least with Part B. And Part B is the outpatient and physician office side of Medicare. They were paying using this customary, prevailing, and reasonable charge system that basically looked at what a physician traditionally billed, what physicians in the area billed, and compensated them accordingly. And so you wound up with like very dramatic variation nationally in what physicians who were providing the exact same services were being reimbursed by Medicare for the exact same thing. And so what CMS actually did, they commissioned this Harvard study to actually look at relative value and relative use. And what that study basically did was try and look at how much time different procedures took and how much effort those procedures took, and constructed a relative ranking across them. And in doing so, they constructed this resource-based relative value system, which is the underlying system that pretty much all of our outpatient care uses, even private care at this point. So, you're looking at this and you're thinking like, oh, this is Medicare. No, this is like pretty much every form of insurance is using this resource-based relative value system as its underlying basis to determine reimbursement. So you have this system that's set up, and each procedure is basically ranked, but then the procedures are actually subdivided into components. So you have a physician work component, a practice expense component, and then a malpractice expense component. And those vary across each procedure. At the same time, you have geographic adjustment that takes those fees for individual procedures and localizes them. So really, I mean, you asked for a 1,000-foot view, and I started already getting into specifics, but really you have this system that has thousands of procedures that CMS is attempting to rank, relatively speaking, and then not just adjust for the relative work effort, but adjust geographically for differences in the cost of operating a practice. So you have a lot of problems there with doing it right, even if you're trying to do a good job. And I can give you an analogy with that, with my failure, both as an economist and as a parent. I set up a work chart for my children at home to try and incentivize them to select particular things to do around the house. And yeah, I'm basically setting a fee schedule in the same sense that Medicare is. And what I noticed is that the tasks that I had overvalued, my children had selected right off the board immediately. And the tasks that I had undervalued were left up on the board. And then when I asked why is no one vacuuming the living room, they colluded against me and asked me to raise the price. So, you're looking at this stuff and you're thinking like, even in my own house, I can't construct a fee schedule that would appropriately allocate resources to actually get things done. Now, imagine CMS is trying to do that with a fee schedule to get physicians to actually provide appropriate care. I would not want to be tasked with that.
Yeah. Well, there's two elements to it. There's the we have a defined product, a defined procedure, defined thing. How do we price that? The other is how do we even come up with, in some of your work, so how do we even come up with the relevant box we're going to check? Because, in non-healthcare markets, yes, it's one thing to say an apple. I'll take an example from Seoul. You could set a price for peas. Well, quality of peas vary by, how regular they are, how green they are, all these kind of things that a can of peas, can vary on. So how do you even come about defining the product is much more complicated than, I guess, in my household, I know that sweeping, vacuuming, this stuff needs to be done. So how do they even come up with like what counts as a procedure?
So they have underlying justifying elements for each type of code. And like a typical bread and butter visit to a doctor is an evaluation and management visit, which has a problem focused patient history, an exam, and then medical decision making. And across all three of those elements, you have variation in what's acceptable to justify a particular visit code. Now, the issue with that is, even if you look at scenarios, and there was some literature that actually looked at this, that was the underlying basis for my dissertation. But basically what would happen is doctors would come up with a scenario and write it down, and then they would hand it to other doctors and ask them what the code should be coded as. What does this scenario declare from the standpoint of the underlying code? And there wasn't a lot of agreement between physicians about how visits should be coded. So then the next stage of this research was basically looking at expert coders. And eventually, if you look at some of that research, even expert coders didn't really agree a good chunk of the time. So you have a predefined scenario, you have expert coders and expert coders, and the intercoder agreement is abysmal. So the underlying justifying elements for these are kind of ambiguous. So you're talking about a clearly defined product. And what I would say is with a lot of healthcare, the justifying elements are so widespread and so all over the place that you don't even necessarily have a clearly defined product.
Yeah, I think that's a really interesting thing. One of the kind of critiques of the basic competitive model is, oh, you start in a world where all these goods are homogeneous and everyone agrees on value and stuff like this. And here it really is, in addition to all the regulatory and asymmetric information stuff that Josh said in his opening question, like, it's not the same thing. It's not the same product across both the supplier side. You're talking about the doctors or the coders calling these different products, but definitely not on the consumer side either.
And so I think with your work, one of the interesting things is that when Medicare is setting all of these reimbursement rates, they have like these arbitrary restrictions. And those arbitrary restrictions end up creating geographic variations in prices that are not really necessarily associated with geographic variation in cost, right? And so if that's the case, then it's possible to look at people in these different places and see how this sort of like relative reimbursement kind of affects their incentives. So maybe you could talk a little bit about the work that you've done on this geographic variation and kind of what you found about how doctors behave given those incentives.
Yeah, so the way that the fee structure is structured, if I start with a particular procedure, Medicare and this resource-based relative value system attempts to take a procedure at a national level and reimburse it in a locality or in a location where it's delivered um, and reflect the cost of care in that particular area. Now, the issue with this is that, for example, that physician work component that I was describing, when they actually do that geographic adjustment, they look at occupations outside of medicine to eliminate some of the potential endogeneity. So they look at architects, lawyers, right, professional occupations, and they look at median hourly earnings using basically a custom BLS pool of data. And they use the national wage bill for each of those occupations to construct a weighted average. And then when they actually do the geographic adjustment, they only permit for 25% of the observed deviation. So,
So it's always going to be squeezing the prices relative to other, not systematically deviating like one way or another. It's always going to be making less variation in the price than you'd maybe suspect from other cost measures.
yeah. So, and the other thing that this does, if I'm in a high cost area, I'm going to be systematically underpaid because this mechanism isn't fully adjusting for the fact that the cost in my area is actually higher than what the Medicare fee schedule allows. On the other side of things, if I'm in a low cost area, I'm actually going to be overpaid. And what I've seen in the literature, especially in public health, is you wind up with people with really erroneous conclusions. They'll start concluding that being in a rural area that would typically be a health professional shortage area actually has improvements in the quality of care or something along that line, and they're not really fully adjusting for the fact in terms of their analysis that these areas are actually being overpaid relative to the national fee schedule. So you have that with the physician work component, which has been there for a long time. The other aspect of it, through the Medicare Modernization Act of 2003, they actually put a floor on the physician work component. So instead of actually adjusting the fee schedule down for an area that has a below average cost of living, it's held at 1. So you have these areas that were overpaid, and then through that restriction, they've actually overpaid them even more.
How does that fit with at least my understanding of the popular narrative is that there's always a shortage of doctors in rural areas. Is that Is there something to that? Is there some other effect going on to that story, or how does that square with this idea that they're also going to be overpaid?
Well, so I don't know how much I want to get into the health professional shortage area piece, but I'm actually working on a paper right now related to that.
Mhm.
There's a lot of underlying components that go
Mm,
into whether an area is classified as a health professional shortage area, including low infant birth weight, right? Like a lot of things that you wouldn't necessarily think about. Most people,
mm,
when they think about a health professional shortage area, think about the more simplistic definitions in terms of provider to population ratios. The way that they actually construct that, it's a scored algorithm that's relatively obscure.
mm.
I don't know that I necessarily see the same underlying justifications there to actually classify an area as a HPSA.
Mhm.
I guess the other issue with that too is there's also a bonus payment for a physician who's operating in a HPSA. So on top of
From
this regular fees,
from, like, Medicare, you mean? In
yes,
that
yeah.
yeah, yeah.
So if you're in a geographic HPSA, you actually get a 10% bonus
Mm.
on the fee schedule. So there's a lot of these things that are actually present
Yeah.
in terms of any of the fee adjustments.
And should we think of those as rural? Or
Uh,
is there more the underserved or the low physician? Is it the most rural spots and it's a broad statement, or is it a little bit
I
more
would
complicated?
I would say it's a broad statement
Yeah.
because you have to take into account both
Mhm.
the population's healthcare needs, and the number of alternative
Mhm.
providers that are actually in the area. The other issue is even if you look at a primary care service area, um, depending on whether you're looking at rural or urban, the size of the primary care service market actually changes pretty dramatically.
Mhm.
The paper that I have in health economics a few years ago that actually addresses the size of a primary care physician market.
Mhm.
If you go up to Atlanta, there's some primary care service areas that are only 2 or 3 miles. You go to a more rural area, patients might be willing to travel 40 miles to see a primary care provider. So, I mean, we
Mm.
talked about product market, but you also
Yeah.
have this geographic market that varies based on whether we're looking at rural or urban.
And you're not getting it shipped in like you're getting your apples shipped in. It's a non-tradable good in that sense. So
Right,
the
right.
geographic distribution matters a lot. I didn't mean to derail things with this rural and urban, but I got a lot of family in rural Minnesota that actually was just talking with someone this past weekend that isn't going to move somewhere because they couldn't get to a hospital in time. They would have to drive themselves, and they're getting up in age, and just it caught my attention thinking more about this rural and urban. So we can jump back to more general fee distribution stuff. Um,
Yeah, so I mean, if I get back to what the implications of these imperfections are, right? I mean, you have all of these imperfections that are present, and a lot of the work that I've done historically has basically constructed uh, a a fee that you would pay physicians if you removed all of these imperfections, right? And then I look at that measure relative to what you're actually paying them, right? So basically it's a measure of payment generosity. And I mean the iterations of this have changed across the different papers that I've written based on the policies that are in place or even just from the standpoint of the evolution of the construction of the measure. But generally what you see is that areas that have more generous reimbursement have higher quality. But the other thing that I've actually noticed with it is that some of the underlying assumptions that CMS makes from the standpoint of supplier induced demand actually come into play. So, given the fact that physicians have so much discretion over the services that they provide, and the fact that we have these asymmetric information problems, and this principal agent issue in terms of patients relying on the physician to appropriately diagnose and treat them, it's pretty easy for a physician to actually induce demand. And I've had this debate with a lot of people more recently. But if I go in to see a physician and that physician has actually seen their services reimbursed less, it's fairly easy for them to say, okay, well, I've treated you today. I want to see you in 2 weeks. for a follow-up appointment to make sure that this condition isn't any worse. And the patient or the beneficiary actually feels good about that, right? They're happy to come back, even though that follow-up care might not actually meet any criteria from the standpoint of efficiency. So you have this mechanism, this clear mechanism in terms of a follow-up visit that physicians can use to essentially offset a decline in their service revenue caused by these imperfections in the fee schedule.
Because it's a restriction on the price per unit, a defined unit of quantity. You can't affect the price. Well, you can affect the quantity, right? By increasing a second visit.
Yeah, so I've got ambiguous justifying elements
Mhm.
for a visit, which can cause me to change the code that I actually use to begin with. I can up code, but I can also say, Josh, I'll see you in a week to make sure that this condition isn't any worse. And Josh feels great about that because his doctor's concerned.
Yeah, and he's not paying for it directly, so you have that other issue, right? If you're a mechanic, I often think about the connection between mechanics, car mechanics, let's say, and health providers. You could conceptually separate the diagnostic from the treatment, but because once you've done all the diagnostics, it's my understanding, once you've done all the diagnostics, it's relatively low cost to do the fix, so we tend to see those bundled, right? But if your mechanic said, okay, bring your car back in a week, like, no, I'm not going to bring my car back in a week. Why would I do that? Because you're gonna make me pay another hour's worth of labor. But if the insurance is paying for it, sure, that's great.
So the issue here is under Part B, without any supplemental insurance, beneficiaries only have a 20% coinsurance rate. And they have a very low deductible. So it's pretty easy for them to get to a territory where they're not very concerned about the potential costs that are being imposed on them from an additional visit.
Now, the other thing is, I was going to say, can you talk a little bit about upcoding? Because I don't think that people understand. Like, if you explain reimbursement rates to people and you explain how that they're set up and you explain, like, oh, there's these different categories and all of these things, right? It sounds very organized, right? It sounds very like black and white. But at the same time, if you're a physician and somebody comes in and, like, let's say they have bronchitis, there might be a separate code for, like, treating someone with bronchitis versus treating someone with pneumonia. Well, someone who has bronchitis has a lot of the same symptoms as somebody who has pneumonia. So you might actually just code that you treated them for, like, pneumonia, even though it turned out that they didn't have pneumonia or something like that. And so, like, how do those sorts of incentives play into these reimbursement rate problems?
So the bread and butter evaluation and management visits that you typically have when you go to the doctor, their CPT, current procedural terminology, 99211 through 99215 visits. The 99211 is if you see a nurse practitioner. If that same nurse practitioner is practicing incident to billing and you've seen the doctor that they serve under, that could actually get billed at one of those higher codes as if you saw the doctor themselves. At the same time, I mean, if I go back to these justifying elements, if you look at those codes as the clinical complexity of even the patient's history increases, you can move from a 99212 to a new 99213 all the way up to a 99215. So let's say that I have a patient that comes in that has diabetes. I have diabetes in their electronic file. I can pre-populate the electronic health record that's attached to the visit that I'm going to bill Medicare with diabetes as a complicating condition of the visit, even if this visit has nothing to do with diabetes. And now all of a sudden I've met the underlying justifying criteria to bill $50 or $60 more than a visit that has nothing to do with diabetes at all. So these underlying criteria for a visit and its justification are pretty flexible, and that provides a lot of discretion to move these visits within categories. And what I was saying earlier is, if I look at a scenario, doctors can't necessarily agree on which code to use. Well, if I have some ambiguity in which code to use, it's going to be very difficult for CMS or a contractor who's trying to get this money back because somebody's committing fraud, um, to come back and actually justify that this isn't just variation in practice style. So, a lot of the codes within Medicare and within this fee schedule, they have relative differences in intensity for comparable procedures, and the justifying elements for these things are quite different, um, from the standpoint of underlying justification to move across categories, which provides physicians with a huge opportunity to increase codes to maximize revenue, which is effectively upcoding.
Mhm.
I've gotten into it with a couple of referees about what this actually means. Some people were actually trying to describe upcoding as purely a change in billing, but I think that that's a little naive from the standpoint of the underlying content of the visit, right? Because if I know what the underlying relative justifications are for particular codes,
Mhm.
the content of a visit actually becomes endogenous, right?
Mhm.
I can modify the underlying justifying elements and actually do them. I'm not committing
Yeah.
fraud in that case. I'm just maybe not providing appropriate care.
I could ask you how your diabetes is doing, and that's now I'm checking in on your diabetes, even though that's not what you came in for, type of
Yeah,
thing.
and you
Yeah.
you hold up your tablet and you check
Yeah.
that box that you checked in on my diabetes, and now all of a sudden it's a higher billing code.
Yeah, it's as someone with a newborn that just went through a lot of billing, I'm getting a little trigger warning I should have gave myself on this interview. So that makes a lot of sense to me. It's super interesting responding to incentives, but you're very much an applied, that'd be that, an applied level getting into the data on this. How do you actually identify that? How do you find that evidence of this in the data?
So a lot of the earlier work that I was doing was concentrating on exploiting geographic differences in this generosity measure. But some of the more recent work that I've done has exploited specific policy changes. So, for example, I have a paper that's minor revision right now. I'm hoping that's turning into an acceptance, maybe hopefully this week. But that paper is actually looking at the primary care incentive bonus payment program. It basically provided physicians who are specifically primary care with a 10% bonus payment on their evaluation and management services from 2011 to 2015. And in that paper, what I basically did is I identified everyone who was continuously eligible for this program. And then I used their entire distribution of CPT codes to identify specialists who are effectively behaving identical to primary care physicians. So, I basically used Lasso Logit with every CPT code that the providers actually build with binaries to select a set of CPT codes that define primary care versus specialist. And if you look at the iterations of that, I could basically use that model to predict whether a physician was a primary care physician with about 90% accuracy. So I use that to actually weight primary care and specialists. And what I did, this program expired after 2015. So I actually you have this temporary fee bump, and when this fee bump ends, you expect some sort of a reaction from the standpoint of behavior. Do physicians expand volume or do they cut volume in response to this? So from the standpoint of offsetting and supplier induced demand, uh, the theoretical ramifications of that model would suggest that physicians actually cut back on services when they receive this fee bump. And when the fee bump ends, you would actually expect them to expand services. And if they actually behaved with a traditional supply response, you would expect the opposite reaction. What I actually observe in terms of a difference in difference model is that when the program ends, they actually expanded service volume. And if you look at the magnitude of it, it's about a 48% offset, which is consistent with historic CMS estimates of offset of their offset assumption. So essentially, what I've been doing lately is more of the traditional difference in difference that seems to be the bread and butter of every health economist. I think it pretty credibly deals with how we react to payment reductions or increases.
Well, and one of the things you brought up, and this is something I wanted to talk about, because to me, the attitude towards this concept has completely changed. So once upon a time, our listeners will be surprised to learn that I passed a health econ field exam. Okay. And so, back then, okay, there was this idea of supplier induced demand, and it seemed kind of popular, right? It seemed like kind of a popular idea. And then fast forward like a decade, and there seems to be a lot of doubts about this, but I'm not really sure why there are these doubts about it. I mean, I guess we can speculate, but the supplier induced demand story is something that I think people understand it well. Like Brian's example was a mechanic, and so the attitude that people tend to have towards mechanics is like they're ripping you off. Like you go in and they tell you that there's this part that needs to be replaced and you've never heard of this part before in your life, right? And so you wonder, okay, are they really fixing something here, or like what is going on, or are they replacing something that doesn't actually need to be replaced just so that they can bill me for something? People don't really have a hard time believing that mechanics do that. But when it comes to doctors, people do seem to have a hard time believing this, apparently. That a doctor might tell you that you need something that you don't actually need, or that doctors might behave in like these kind of strategic ways. So can you kind of tell the listeners what supplier-induced demand is, and then maybe we can talk about what evidence there is that it does or doesn't exist?
So supplier-induced demand is effectively this underlying theory that you have this principal agent problem in healthcare, where you as the patient are relying on the physician to actually diagnose and provide appropriate treatment, right? And the analogy of a mechanic is quite similar to what you have in terms of supplier induced demand, in the sense that the physician has this conflicting incentive between and based on their underlying utility maximization, between their profit motive, right, and the underlying disutility from providing unnecessary care, right? So you have this direct conflict that they actually have, and the underlying implication of that is that from the standpoint of supplier induced demand and inducement, if a provider receives a reimbursement cut from a major insurer like Medicare, it could actually create income effects that are substantial enough that they actually decide to offset the reduction in income through increased intensity.
Income for the physician.
For the physician, yeah. So I mean, if I'm going to place this in the context of kind of what's really going on, I mean, most people aren't thinking about a physician from the standpoint of either being a solo practice owner. They're essentially a private for-profit firm, or they're a partner in one of these firms, or ultimately, even if they're owned by a hospital, they might be being reimbursed based on their share of practice billing. So in any of those scenarios, revenue that's coming in is actually important. Now let's couple that with $200,000 to $300,000 of medical school debt, and let's think about what our individual incentives might be. Right? You might not feel bad about inducing demand at all if you're actually checking up on patients that were ill. But the other thing too is Medicare for the average primary care physician is, depending on specialty, somewhere between 25 and 35% of their revenue. So if Medicare cuts fees, it's going to definitely impact their bottom line. The fact that some other researchers have found evidence that private insurance directly targets and mimics the Medicare reimbursement rates when they set their fee schedule implies that whatever effects that Medicare actually sets in place by cutting fees are actually going to be mimicked by other insurers. So, the implication of that is if an insurer like Medicare cuts fees, physicians might not necessarily behave in a traditional way by cutting back on service volume, right? In the way that you would normally think about it. They may actually expand volume in an attempt to offset that fee reduction. And that's kind of the underlying idea behind supplier induced demand, and what Medicare describes as offsetting.
The way you describe it there, it sounds almost like a backward bending supply curve. But what's the distinction in your mind between that effect where, okay, we raise the price, now I make enough money that I reduce how much service I provide, versus where's the induced demand come into that story?
So the induced demand in that case is, well, I mean, if I go back to talking about the backward bending supply
Yeah.
curve, there has been some labor studies related to health economics
Mm.
that actually would suggest that, right?
Mm.
If I raise physician income up high enough, you may wind up with a physician practice that decides to close on Friday and Thursday instead of just Friday,
Mhm.
right? So you can wind up with that kind of behavior.
One of the things that's kind of interesting about this is that it's not just volume, right? So physicians can optimize on a variety of things. So when I think about a doctor visit, one way that I could, one way I could deal with having my reimbursement cut is I could just see more patients a day, right? Or, the other thing that I can do is I can actually, make, I think the term, is like intensity, right? Like I can increase the intensity of the visit, right? And so there's multiple margins on which you can kind of adjust here and adapt the way that you practice medicine to whatever these changes are in the fee schedule.
Yeah, so I guess along that line, I could actually adjust my billing purely through changes in intensity or through changes in volume or both. So do I see an actual change in service volume? It's really going to depend at the margin on whether I believe that I can justify uh, billing at a higher intensity, or the distribution of intensity for a particular code versus providing additional visits. Because I mean, one of the elements here that you have to keep in mind is you have CMS and you have private firms that are attempting to detect cheating, right? To basically try and get some of the revenue that these physicians are getting paid out back under false claims accusations. So, the relative cat and mouse game here is, what does the distribution of my CPT codes look like compared to a physician with a comparable patient mix and area? If my distribution is a little too intense, I might be under more regulatory scrutiny from the standpoint of CMS contractors who are looking for fraud and abuse.
Like the implications of this are important. Because if you're Medicare, why are you cutting fees? Generally, like the justification for cutting fees is like we're trying to control the costs, right? We're trying to control the cost of care. But if you look at Medicare, Medicare actually assumes that governments do that, or Medicare actually assumes that physicians do this. So, like, if they are going to cut fees by $1, they don't assume that this saves them $1, right? Like, they assume it saves them like 80 cents or something, right? Because they anticipate that when they cut this fee, doctors are going to behave in this way. And I think that that's an important point, right? Is that like this literature has to wrestle with. If you want to make the argument that doctors don't behave this way, you have to explain like why Medicaid or why Medicare does these makes these projections where they basically assume that doctors are going to do this anyway.
So this is actually the place where when I'm dealing with referees who are hostile to the idea of supplier induced demand, I usually point out the CMS actuarial reports that actually have the underlying assumptions, and they seem to have a hard time grappling with that. Yeah, I mean, if I'm looking at this from the standpoint of this fee schedule, the way that the fee schedule is actually set up is in such a way that any changes that they make are expected to be budget neutral. So if they predict what costs are before and after the change, for example, changing the RVUs for particular procedures, the total cost in terms of prediction for the year can't be different before and after that adjustment. Well, the fact that you're changing the prices of particular services at the margin implies that physicians are going to respond, and maybe in a way that you can't necessarily predict, right? Which automatically means that these changes to the fee schedule can't really be budget neutral.
Can you, as not me as a nobody, but you as somebody who understands this stuff, you can see the full prediction, their full model of how they come up with it? Is it like a CBO projection that you can back some stuff out?
So I have seen what the projections are. I haven't looked at the underlying structure. I don't know if that is because I got bored trying to dig through it, or if it's not actually there.
Yeah.
Usually the underlying assumptions for those things are they're not as sophisticated as something that I would do. So I don't know that it's something that I would have really dug into.
So another area that I think is important. So like one of the things that I see when I look at health economics, so I can throw stones from outside. One of the things that I see is like there's so many people who are like going after what I would call like low hanging fruit. And what I mean by this is like you see like the Affordable Care Act. And so the Affordable Care Act effectively makes like being uninsured illegal. And then you have people who are writing papers that say, did the Affordable Care Act increase the number of insured people? Well, I mean, I think if we make it illegal, we're going to see an increase in the number of insured people. Maybe that's not like the margin that we care about. And you see this too with like the Medicaid expansion. So with the Medicaid expansion, the low-hanging fruit is, okay, now these people who weren't eligible for Medicaid are now eligible for Medicaid. And so let's see how many of these people, take up Medicaid, and let's see what their health outcomes are. Well, I would expect that, some of these people are going to take up the expansion, right? And some of these people are going to have better health because now they're going to the doctor when they wouldn't have gone to the doctor otherwise. But there are other margins of adjustment here. And so when it comes to Medicaid expansion, one of the things that I know that you've done is you've said, okay, let's look at the effect of the Medicaid expansion on Medicare patients. So why would we look at Medicare patients and what do we find out?
So a lot of the time when I was looking at the literature related to the ACA expansion, I personally, I feel like the bias in terms of that literature is towards finding these kind of accounting identities that you're talking about. If I offer people free insurance, do they take free insurance? If people have free insurance, do they use healthcare? I mean, I'm sure that those are interesting questions to somebody, but I kind of find them boring, right? I mean, a lot of what we try to do in economics is look for unintended consequences. And, this experiment, I think, was a natural place to actually ask a question related to people who had insurance before. So, you have this insurance expansion, which in some places expanded Medicaid enrollment in a state by, a third. Does that have spillover implications for people who are privately insured? Does it have spillover implications for Medicare, or even people who are enrolled as traditional Medicaid enrollees who are more vulnerable. So those kind of things. And last year I actually looked at the impact of the expansion on Medicare service volume, and this was basically like a county level analysis, using a difference in difference. And what I basically found is that evaluation and management visits declined for Medicare beneficiaries. So from the standpoint of spillovers, there were definitely some negative spillovers on the Medicare population from increased crowding at physician practices due to increased Medicaid enrollment. And there's actually been some recent papers that have looked at that with respect to private insurance too. So, both privately insured and Medicare beneficiaries have seen some negative effects associated with this expansion. Now, the problem that I have is the resistance within the community to potentially identifying those pitfalls associated with the expansion. I've noticed quite a bit of resistance to the paper that I wrote, which demonstrated some potential negative effects from the Medicaid expansion. People were very resistant to that, despite the fact that I wasn't making any claims about the net social benefit of the policy. It was really just illustrating a potential negative spillover. And we should all really want to know what the pitfalls and what the ramifications on alternative populations are when we impose particular dramatic policies like this.
I think that's one of the things that makes your work so interesting is this part that we call price theory, this tracing out through other markets. Kevin Murphy in some lecture says, the biggest impact of the ethanol subsidies may not be actually on corn, but on the land market, because you drive up and so you need to think about not just the one market, but the market right next to it. So the compared to kind of the more standard, straightforward diff and diff type of analysis, where you're going to look where the lamppost is type of framework. So you brought up private insurance. I want to talk a little bit more about the connection between Medicare, Medicaid, and private insurance. Because one, I won't call it naive, I'll call it the Brian's perspective. One Brian perspective is like, oh, you kind of have two operating markets side by side. Prices maybe reflect one. You raise prices in the private market and may drive people to the subsidized market, so on and so forth. But you said something earlier about how the pricing system of these private insurers tends to closely match Medicare, Medicaid. I wonder if you could talk a little bit about why that's the case and what that maybe tells us about the Medicare system. Is it actually doing pretty well because it's following the best pricing we could get with private incentives? Just talk a little bit more about the back and forth there.
So I think what some private insurers are actually doing is using the Medicare fee schedule as the basis of their schedule with a percentage markup, essentially. So there's some work that's actually looked at Medicare fees for hospital services and private fees, and changes in those Medicare fees and what happens in terms of private fees. And if you look at like what the CBO estimates with that, or what some of these other researchers have actually estimated, is somewhere between 115 and 120% of that 100% for the Medicare fee is basically what private insurance will set their rates at. So you basically have a slight markup. On the Medicaid side, some state Medicaid programs will actually target the Medicare fee for a particular service and discount it to 80% of whatever that Medicare fee is. So you wind up with this setup where basically, intentional or not, Medicare is actually acting as a leader in the market. Now, whether that's efficient or not, if I'm going back to this thought that I have about me trying to set prices in my house to do chores, and I mean, I think that they're doing their best, but I also think that some of the alternative actors that are in this market um, may not necessarily create the same price incentives that would happen under an independent scenario. So what I mean by that is you had this Harvard study that basically constructed these relative value units across procedures, but then you have basically an AMA relative value update committee that is composed of predominantly specialists who meets annually to try and decide on how each of these fees might get adjusted. I don't know the internal mechanisms that are occurring there that create changes in terms of the fee schedule and what the ramifications are. But what I do know is, if you go back to 2008, MedPAC was actually suggesting that primary care services had been systematically undervalued by the fee schedule. So, and this is basically relative to specialist procedures. I don't know how much of that is due to the relative composition of that relative value update committee. But what I do know is based on that recommendation, this primary care incentive bonus payment program came about. There's just so many different underlying ramifications of all of these nuances associated with the fee schedule, some of which it would be very difficult to predict. And some of it is basically historic. I mean, when I talked to one of the architects of these geographic practice cost indices and asked about this 25% restriction, what I was basically told was that this was the only way that they could get it through. So from that standpoint, how much of this fee schedule is actually designed from the standpoint of efficiency, and how much of it is designed around historic constraints and the influence of interested parties that are adjusting the fees. On top of that, you have private insurance and Medicaid that are just basically mimicking it. The ramifications for efficiency, I'm just not clear about.
Yeah, that's that's a fair response, that there's not really a clear uh, efficiency issue, or we don't know what the clear efficiency gain would be. I think the important thing is just realizing how complicated all these interconnected markets are, and it's really actually not that much, maybe gloss over it in other markets, but you know, when a big corporate retailer is setting prices, they don't necessarily have all this information either. They are groping in the dark. They have incentives to kind of, individual employees have incentives in that firm to set uh to favor their prices in some sense. It's I think that's the thing that makes it interesting, is trying to trace out and understand all these interactions.
Well, and one of the things I think that's difficult about this is if you look at all the textbook models about how to set prices, there's usually some kind of um, like comparison, right? Like there's generally some sort of like, okay, well, we're going to set prices. So how do we do that? Well, we just look at, you know, um, we just look at what everybody else is doing, and then we decide like how, how we can adjust that, maybe to get rid of some of the profit margin or something like that, if you're Medicare, for example. But the problem is that if Medicare and the private insurers, like if Medicare is setting reimbursement rates and then private insurers are making their reimbursement rates conditional on like what Medicare is doing, and they're using Medicare as the reference, then there's no actual reference. And maybe this is why, like when you call a doctor's office and asks how much something costs, they can't tell you, right? If you ask for the price of basic things, they're like, oh, well, I don't know what that is.
That changed recently. Was there some transparency change?
Are you referring to the hospital transparencies?
Yeah.
So there was a Trump era regulation that if hospitals didn't want to be subjected to a penalty, they had to basically produce a price schedule.
Mm.
Now, the problem with that regulation was that they didn't specify how it would be reported on the website. So a lot of hospitals intentionally hid it on their website through a series of basically JavaScript restricted clicks. I actually had a group of students for extra credit. I was paying them piece rate extra credit per downloaded file. And I used the number of hospitals in Texas as a reference to figure out the baseline extra credit that I would provide. The quality of what I got out of some of the students was a little questionable, so I haven't done much with the data. But I mean, was that data available? Yes. Was it reported in a format that the average consumer could really understand? I don't think so. It wasn't a standardized format. And some of them were actually reporting it in formats that you would have to web scrape to get any data out of. I mean, it was relatively abysmal.
Even more price theory lessons there. The trouble of implementing regulation in the way you want, and how people are going to find ways to work around it. The fact that knowledge isn't free. It's on the website. That doesn't mean that consumers can use that knowledge. A lot of great stuff in this field. It makes me almost want to do health economics. Maybe we should write a paper, the three of us.
I like it. So there are other components from the standpoint of transparency that data is very well available to consumers. If you look at the Affordable Care Act, Payment Sunshine Act, you can actually go on the Open Payments website and look up an individual physician and see exactly how much they were reimbursed and in which form from pharmaceutical representatives. You can basically do that every year from 2013 on. You can look at what kind of drugs they were actually receiving transfers for, all of that stuff, and it's all centralized in a way that it's easily accessible to someone. I wish that some of this hospital transparency and even some form of physician transparency data would be available. If they had that in a public website, you might even be able to support some level of yardstick competition across physicians by seeing what they're actually agreeing to accept across different regions.
That's a really nice spot to wrap up. Thank you so much, Chris, for joining us. It's been a really interesting conversation. We'll have to have you back on again to talk about it on Economic Forces Podcast.
Thanks for having me.